Hello, everyone, and welcome. Thank you for tuning in. My name is Dr. Brian Hughes, and I'm the Medical Director for Palliative Care at Crossroads Hospice and Palliative Care in Kansas City, Missouri. Just a little bit about myself. I grew up in the area and went to school actually at the University of Missouri, Columbia. Did my undergraduate degree in medical school there, and then I came back home doing family medicine, or actually practiced rural family medicine and then more suburban family medicine for about 10 years. Shortly into my family medicine career, I started doing some hospice care on the side and really fell in love with it and started doing more, became involved with a couple of different hospices as a part-time medical director and just found a passion for it. So I went back and became board certified in hospice and palliative care. And then in 2018, made the jump to full-time to be with Crossroads and managing their palliative care program here in Kansas City. So today I wanted to talk about palliative care and really where it's come from and what it is, and then where it's going. And the title, Achieving Patient-Centered Goals at the End of Life, is really what palliative care is all about. The idea of palliative care is not new by any means. It's been around for a long time, but palliative care as a specialty field is new, and the way that that care is being delivered is fairly new in the course of medicine. So the objectives for today's talk: first, we'll explain the definition of palliative care. Seems like a good place to start. And then we'll describe the difference between palliative care and hospice. So this gets to be a little bit tricky for a lot of different people, medical professionals included, just determining what the difference is between palliative care and hospice. They do overlap, and there are some similarities, but there are some differences as well. And we'll talk about that. We'll understand the components of each hospice and palliative care team. So a fairly big difference right now in the way that care is being delivered for those two services. The idea and the ultimate goals of each service are similar, but the way that that care is delivered at this point in time is different, and we'll talk about that. We'll understand the goals of what hospice and palliative care can provide for patients, caregivers, and their families. Ultimately, that is what's most important, and that's what we're setting out to do, is to take care of the patient as a whole, not just the patient, but everybody around that patient who's providing care for that patient. We'll understand the basic concepts of how hospice and palliative care services are billed. This is not an exciting part of the discussion, but is very important to understand the way that those services are delivered, and then also the reimbursement for those services and how that works. We'll describe the similarities and differences in insurance coverage for hospice and palliative care. That certainly is important in today's healthcare age. And then lastly, we'll describe the role of hospice and palliative medicine in the expanding movement into value-based care, and some of where things are headed, and also where I hope things are headed here in the near future. So a good place to start. What is palliative care? We'll start with the definition, and this is straight out of Webster's dictionary. So palliate, the word palliate by definition means to ease without curing the underlying disease. Also to reduce the violence of, and trying to disguise something bad. So when we think about what does that mean? Well, palliate really, when you look at those definitions, provides comfort. And so when people hear the word palliative care, and when we talk about palliative care, we really talk about comfort care, and that can mean a lot of different things, but that is what we're providing here. So by definition, we are easing, we are providing comfort without always trying to cure the underlying condition. So palliative care is certainly meant to help ease the burden of conditions which typically are irreversible, progressive type of conditions, and we'll talk about what those are. And it doesn't always mean that patients have an incurable disease, but unfortunately a vast majority of them do, and that's what we are here to help them with. So when we talk about palliative care then as a specialty, and we'll get more into this, but in essence, it's a medical treatment to help patients alleviate suffering that often accompanies those serious or life-limiting illnesses. And this typically starts with physical symptoms, and a lot of folks think of palliative care providing comfort for physical symptoms, and this is absolutely true, but it's also emotional support, help with spiritual symptoms, help with caregivers, and again, it's the whole patient and the dynamic of that patient that palliative care looks to provide support for. So to talk a little bit about the difference between hospice and palliative care, because this can be confusing, the way I talk about it is that palliative care is a broad term. So when we look at what we just defined palliative care to be, we provide comfort for patients who are dealing with often life-limiting or life-threatening illnesses. Palliative care can include hospice, but theirs aren't always the same, and that gets down to the care delivery model. But there's still confusion over the differences, even among medical professionals, and really at any aspect of the healthcare profession. I see that every day. There's confusion about what is hospice, what is palliative care. Are they the same thing? Are they different? And hopefully by the end of today's talk, we'll have more of an idea of what the differences are. The way I explain it often is it's like an umbrella. And so when we talk about palliative care and all of the support it provides and all of the conditions that we help to treat, that is a big umbrella. It covers a lot of patients, a lot of different conditions, and a lot of different disease severities and patients who are in different stages of those diseases. When we talk about hospice specifically, hospice is really just a box underneath that umbrella. So it's a very specific set of criteria that patients have when they're involved with hospice care, and we'll talk about that. So with that umbrella analogy, hospice is definitely part of palliative care, but palliative care does not always mean hospice. There is a big segment of healthcare that includes palliative care that is not hospice. And so understanding that while they are similar, palliative care by definition does not always mean hospice. And so that's important to remember, especially when we're talking about presenting this to patients, families, but then also healthcare providers too, that you can have palliative care and have it not be hospice. Hospice is really based a lot on CMS criteria. So CMS really dictates and regulates what hospice is, what it provides, who gets hospice, how it's provided, how it's reported as far as quality measures. So they really dictate a lot of what we do in hospice. So by criteria, according to CMS, if a patient is on hospice, that patient must have a reasonably determined prognosis of 6 months or less. In addition to that, they are not pursuing aggressive or curative treatment. So these are typically folks who really are towards the end stages of life, and there usually are not aggressive treatments left as options. So we're talking about cancer patients who have no more options left for chemotherapy or radiation, or they choose not to pursue those. We talk about hospitalizations, other invasive type treatments. So by definition with hospice, patients are typically not pursuing those things. Now with palliative care, so as you can imagine, there are a lot of conditions that patients are treated for that don't fall under that hospice category. Patients who have over a 6 months prognosis, or they still are pursuing aggressive treatment, and we still need care for those patients too. So that's where palliative care really has evolved as a specialty to help take care of those patients who don't fall under the hospice criteria, but they still need the same types of care. So with palliative care, at least right now, is not regulated by CMS. And as we'll talk about in a little bit, mostly because that doesn't change the insurance benefit, whereas hospice does. In palliative care, there is no criteria for prognosis. So palliative care in theory can be delivered at any stage of any serious illness. Anybody who needs those services can qualify and receive palliative care. those patients also can be pursuing aggressive treatment. And so we have a lot of those folks that we take care of, patients who are still reasonably wanting to be treated in a hospital for certain conditions. They are still getting some benefit from chemotherapy or from radiation for things like cancer. And so palliative care can help treat those patients who are still pursuing aggressive or even curative treatment, knowing that some patients will succeed with curative treatment. A large portion of those folks may not, but they're still getting benefit from that treatment. And then, as you can imagine, the patients who are no longer getting benefit of that treatment or progressing in their illness, then will go on to qualify for hospice care. So another way to look at it roughly is that palliative care takes care of a large percentage of folks with these conditions upstream of hospice. So typically earlier in the course of their disease. And then as patients progress in their disease, then they qualify for hospice and a lot of times transition right to hospice services. Let's talk about why palliative care is important. And to do that, we'll talk about some of the common illnesses that are treated with palliative care. This is by no means an inclusive list, all-inclusive conditions, but it's just an idea of what kinds of things are treated. Unfortunately, when we look at this list, there are mostly things on this list that we don't have cures for, arguably with the exception now of HIV and AIDS. These conditions a lot of times are not completely reversible. Cancer, of course, a lot of times when we think of palliative care and hospice, cancer pops up because unfortunately a lot of patients have progressive cancers. There are certainly patients who are cured of cancer, and that's great, but a lot of patients are not. Heart disease, including CHF, which is congestive heart failure or just heart failure, is typically progressive and has a need for palliative care. Respiratory or lung diseases, COPD, which is commonly thought of as emphysema, is the most common of those conditions. Kidney disease, progressing to kidney failure and dialysis. HIV and AIDS was a common condition that we'd see for palliative care and hospice, but really with the advances in the medications and the antiretrovirals, we don't see as many folks with AIDS that are utilizing hospice services because with adequate treatment, a lot of those people are able to live a life expectancy equal to somebody that didn't have that condition. And so we would, in essence, are seeing almost a cure or at least life-prolonging treatment in those folks to where hospice and palliative care aren't needed as much with those people. Chronic liver disease, so things like cirrhosis from hepatitis or from alcohol, and then moving into the neurologic conditions, so multiple sclerosis, dementia, including Alzheimer's disease, strokes, and then ALS. So again, these brain conditions, which are degenerative, unfortunately, we don't have a lot of great treatment or cures for at this point. And so there is definitely a need for palliation. Why palliative care? Well, as you can imagine, those conditions that we just listed place significant burdens in a lot of different ways on patients, on their families, and on their caregivers. The traditional medical model, unfortunately, does not always help with that burden and does not always focus primarily on patient goals, and we'll expound on that in just a minute. Major illnesses place a financial burden on patients, on families, and unfortunately on our society as a whole. Put this down at the bottom because certainly it can be hard to think about costs associated with these serious illnesses when patients are in need, and it's not necessarily the top priority, but it is a significant issue and one that we face on a daily basis of the rising cost of healthcare. So when we talk about disease burden with these types of conditions, initially palliative care was primarily built as a specialty to help patients with symptoms, started with cancer patients. And so and it progressed from there to include other conditions, because unfortunately with these serious illnesses that we've talked about, these can often come with unpleasant symptoms. Things like pain, which is often at the top of the list because for most people pain is a distressing symptom. Dyspnea, which is shortness of breath, which can often accompany these types of conditions. Nausea, constipation, fatigue, which is low energy. Depression and other mood changes can accompany these. Swelling. So again, not an all-inclusive list of symptoms that can be experienced, but some of the most common things that we see. These symptoms can either be associated with the disease themselves, just by the disease process, but a lot of times symptoms can come about because of treatment that we're doing from the disease. Just an example of that is nausea that can be found with patients who are having chemotherapy. That's common. So sometimes we actually induce these symptoms by treatments that we're providing, and in turn we need to have adequate management of these symptoms so that patients can be comfortable. So palliative care practitioners really are experts at managing those symptoms, and those symptoms are certainly alleviated using a variety of different methods that are important. So we mentioned that part of the disease burden is that the serious illnesses place significant burden on the patients, caregivers, and their families. And so palliative care not only provides help with symptom management and physical part of feeling better, but also emotional support and support to families and caregivers. So that's done routinely through education to families and caregivers, through social services so that they can be connected with the types of support services in the community that they might need or get help from. Community resources are given, and respite care too, which is essentially when caregivers need a break and they need to be able to have somebody else give care for a short time while they get break, because there certainly is a high level of caregiver burnout, caregiver fatigue, trying to manage patients with these illnesses. So we mentioned earlier that the traditional medical model does not always align with patient goals, and this is a big topic in palliative care. When we look at where we've come just in the last 5 years, 10 years, 50 years, 100 years, modern medicine has made huge advances. We have more medications and technology and treatments and hospitals. We have all these things at our fingertips that can help make us healthier in a lot of cases. But unfortunately, what we often see is that despite all this advancement, we still aren't great at treating some of these chronic, progressive, and irreversible types of conditions. I can take a little bit of blame for my colleagues, because doctors are trained to cure. When I went through medical school and residency training, internship, and then practice, you have a goal in mind of treating patients to get them better, to get them feeling better, and to cure them of whatever is ailing them. And that is typically done through an algorithmic model, meaning if patient comes in with A and B, then you treat with C, and then you move down that pathway. For example, last year in March, I was exercising, doing a workout, and I had an accident. It was kind of a freak accident, and I broke my leg. I broke it through the knee. So when I broke my leg, being relatively young and otherwise healthy, I wanted my physician to absolutely treat me with an algorithmic model. I wanted him to be trained in how to do this surgery appropriately. It required a surgery with a titanium plate, and the placement of that would predict my overall outcome and function level and pain level and disability level. So I wanted my surgeon to be trained on an algorithmic model. I wanted him to know exactly what to do in that situation and treat aggressively as possible to be able to fix me, basically. Now let's say, for example, I was a 90-year-old with metastatic prostate cancer to my bones and to my brain, and I had broken my leg in that case. The discussion might be different because at that point you have certainly other factors to think about other than that algorithmic model of simply broken leg, fix the leg. You've got a lot of other factors. And it's just, we're lagging behind a little bit on being able to look at the whole picture and not just the treatment options, not just the advancements that we've made. And again, I'll take the blame for some of my colleagues that are just not always very good at that. And so part of what palliative care does, as well as treating symptoms and some of the other things that we mentioned so far, is to help put that picture together and look at the quantity of life versus quality of life, because those don't always equate to each other. You can do certain things to extend quantity of life and length of life, but that doesn't always mean that that extra length of life will give you better quality of life, and vice versa. Works the other way around. And so really what it boils down to is we have to look at patient preferences. Again, going back to the title of the talk, trying to achieve patient-centered goals. And so discussion is key with patients, that even though we might have these treatments and medications and surgeries and things that can be done, should they be done? Do patients want them to be done? And knowing what the options are so that they can make the best choice for themselves, so they can make the best choice for their families, that really should be a significant part of what we are focusing on in the medical community, because we have a lot of things we can do to patients, but that doesn't always mean we should do those things. And really it's about doing things for patients and not always doing things directly to those patients. So again, part of palliative care is to put all those things together, not to push an agenda on a patient, but just to give them all of the information that they can so that they can make a good choice for what defines quality of life for them. So because of that, palliative care often requires a shift in mindset. With physicians even, it's often perceived as failure when we talk about palliative care or talking about hospice. It's perceived as saying, well, I guess I must not have done my job if I've made a condition that I don't have anything else to offer to this patient, or if the patient says, here's what I have to offer, but I don't want that. I don't want this chemotherapy anymore. I don't want this radiation therapy anymore. So that's something that I think we're making progress on, but it still is a big issue of not perceiving end-of-life care as a failure. And then we'll also touch on the financial burden of these major illnesses. It's difficult to have an objective conversation, objective stance on this because it's so emotional. When we think about all of the advances in medicine and the things that we can do, and that automatically makes us think about curing illnesses. And so to think that some people might not be able to have access to these because of cost, that certainly has an emotional ring to it, and that's made even more pronounced by discussion about rationing of healthcare, and even to the extreme of a few years ago talking about death panels, to where patients over a certain age just wouldn't have access to certain care, which is not the case at all. But at the same time, it's important to look at that as a whole and decide what types of things financially, economically, make the most sense, that also align with patient goals too. As we're talking about those conditions that I listed, they certainly are expensive to take care of. Newer and in some cases better types of medications and treatments, they also come with a large price tag. One in particular, just to point out an example, is immunotherapy in cancer treatment. We're seeing a lot more of that, and drug companies are coming out with numerous medications that work on the immune system to help fight cancer, either in addition to or in replacement of some of the traditional chemotherapy. but those treatments are expensive. In some cases, they can be $30,000 to $35,000 a month for treatment. And so some of these advances are nice and they're good, and they'll help in the overall mission to treat these conditions, but they're very expensive. And so that has an impact on a lot of us. So we'll take a look at a few of these just to talk about cancer in particular, even more so in the United States. More than 1.6 million people per year are diagnosed with cancer, but still almost 600,000 people per year die from cancer. Still the second leading cause of death. So the cost of cancer care continues to rise, and by 2020, which we're in, these statistics are a little bit older because we don't have some of the newer ones, but expected to reach almost $174 billion for cancer care. It's expensive, and when you look at those odds, if you have 1.6 million people being diagnosed each year, but 600,000 are dying from it, we're doing better, but it still has a significant mortality rate associated with it, despite all of the cost that's being spent on it. Alzheimer's disease, this is a huge one because it just gets more and more prevalent in our population. So it affects about 5.7 million Americans currently, and it is the sixth leading cause of death among all ages, and the fifth leading cause for those 65 and older, and it's only going to get more and more. In 2010, the costs of treating Alzheimer's disease were estimated to fall between $159 billion and $215 billion. In another 20 years, by 2040, it's estimated that these costs could be between $379 billion and $500 billion annually for the overall cost of care for patients with Alzheimer's dementia. So these things are expensive. And that doesn't mean we should not give care to people who need it. But with palliative care, when we put all these things together, really it can be a win-win. When you look at the goals, we help to align the goals that patients have with their treatment. So we want to make sure that they have complete informed consent about the treatments that we're offering. What does this look like as far as symptoms, side effects, quality of life? Does this extend your life? And we want to put together what's important with the patient to tailor that treatment goal to them. We don't want to just offer treatment that they may not want or may not be on board with. Palliative care helps alleviate some of the suffering of the life-limiting disease. So we've talked a little bit about what we do with that physically, emotionally, and that's certainly important with these things. So that's a win for patients, families, and other caregivers alike. Help with caregiver support specifically. That's a job in itself, and it's a taxing job, and it's an important job for patients to get good caregivers and for those caregivers to get good support, and palliative care helps with that. Now, by doing all those things, it is not a primary goal, but it's often a cost-effective method to accomplish these goals. Primary care at this point does not make a lot of money because it takes a lot of time and effort, and it's tedious, but it can save money, and it can save money for hospitals, nursing facilities, insurance companies, patients themselves, and it saves money typically while accomplishing better patient satisfaction, better patient quality of life. And so for those things, it can be a win-win. Just an example, again, just to show the, not saying that we need to withhold treatments because they're expensive, but we deal with this often where patients at the end stages of their illness don't have good success rates if they go to the hospital, if they're at high risk for things like cardiac failure, respiratory failure, kidney failure. And so having that discussion with a patient ahead of time and saying, death is inevitable in this case. You have a condition that is progressive and we can't cure that. And given the options of saying we can take you to the hospital where most likely you'll die in the intensive care unit on a ventilator with IV medications to support all of your functions, and die that way versus dying at home comfortably surrounded by family, not all the time, but a large percentage of the time, patients, when given that choice, would say, well, yes, I'd rather die at home or die in a more comfortable environment with family around me and be comfortable rather than die in a hospital hooked up to a lot of machines. And as you can imagine, dying at home comfortably and peacefully without all those things is cheaper. And so it is a cost-effective method by keeping patient goals at the forefront. All right, moving into some of the differences in between hospice and palliative care, and we'll start with hospice and just a little bit of background. So hospice history: in 1948, Dame Cicely Saunders in London, she began working with the terminally ill and essentially coined the first hospice at St. Christopher's back in 1967. So she took care of the patients who ultimately were expected to die to help support those folks, and that is really recognized as the first type of hospice entity historically. And also just to point out that between 1948, when she started working with these folks, and then 1967, when the really what's considered the first hospice house was developed, and then to 1979, where HCFA, which is the old nomenclature for CMS, initiated programs across the U.S. So when we talk about hospice in the course of history, it's still relatively new, just here in the last 50, 60, 70 years. In 1982, Congress created the first Medicare hospice benefit, which we still see a version of today. In 1984, there was hospice accreditation criteria, which still is very rigorous, that hospices have to be accredited and have certain qualifications met to be able to function. Just as of 2004, we met the 1 million patient mark in the U.S. for patients who had been served by hospice. So again, hospice still is relatively new in the course of medicine when we think about all of that. So hospice by definition then, so patients who qualify, they must have a reasonable prognosis of 6 months or less. And this is as deemed by 2 separate physicians. So 2 different physicians that are involved with the patient's care have to be able to sign off on the fact that they believe that the patient reasonably has a prognosis of 6 months or less. Now, certainly, we're not that good at predicting survival in these patients, so it is a reasonable estimate, and there are guidelines for that, as well as guidelines for what happens if they are on for 6 months and they're still on and they haven't passed away yet, and we'll go through those. But these guidelines are set by CMS. They're essentially the same across the board, but they do differ just a little bit across regions. So you can reference LCD guidelines, or just local coverage determination, and they set the actual criteria for hospice admission for each diagnosis that a patient might have. Again, hospice patients are not typically pursuing a curative treatment. They're just focusing on comfort measures and requirements. So we're still, and this is important to point out the fact that while we're not curing these patients who are on hospice, we're still caring for them. And that's important to talk about when we think about hospice, that some patients think that if I go on hospice, that means I'm just going to be left to die. And that's not the case whatsoever. If anybody's had experience with hospice with a family or loved one, that hospice is there to care and do what they can, but that doesn't include curing for most of those things. We had the list of conditions, and this is just a list of patient types that are common with hospice. Again, this is not all inclusive. There are plenty of other diagnoses that qualify for hospice, but this is just a listing of the most common. Dementia of all kinds, which Alzheimer's is a type of dementia. Respiratory diseases like COPD, cardiac diseases, heart failure, cancers, lung cancer being the most common of those still, cerebrovascular disease, which is stroke, and then kidney failure. So these are some of the more common patient types that we see that qualify for hospice. So there's a specific team that CMS requires a hospice to provide. So this is something that a hospice has to have these team members in place in order to be accredited as a hospice. They have to have a registered nurse to provide care to the patient. They have to have a home health aide to provide certain daily cares for patients. Have to have social work availability to help provide social service and caregiver support. They have to provide a chaplain for spiritual needs. They have to provide bereavement care, and this actually is required to be provided for up to 1 year after a patient passes. So we do still continue to take care of family and caregivers for a year after a patient has passed. Have to have a medical director, so you have to have a physician overseeing the care of these patients. And then there are sometimes optional services. So hospice is not required to provide these things, but can on a case-by-case basis, things like therapy, so physical therapy, occupational therapy, music therapy, even massage therapy. I've seen some hospices offer some of these on a case-by-case basis, but they're not required by CMS to be covered by the hospice. So the care delivery for hospice, so it can be done in several different settings. We provide hospice in the home, provide hospice in long-term care facilities, as well as assisted living. So if a patient is at home or in assisted living, typically they have to have somebody there that's also able to help give care. So hospice is not automatically a 24-hour caregiver support. So hospice is not with the patients for 24 hours, 7 days a week for routine hospice care. And so that's important for folks to remember too, that if you choose hospice to be in the home, that's not a nurse there for 24 hours a day. In a long-term care facility, that's usually a joint venture with that care facility and hospice. So you have the long-term care facility staff and the nursing support there, and then you have the hospice services that come in for the extra support as well. So that's a partnership that we do with a lot of patients. Care is given depending on the patient need. So that's determined by severity of the patient, symptoms, different criteria that determine how often a nurse will visit. That's typically 1 to 3 times per week on average. Home health aide, about the same, 1 to 3 times per week, but it depends on the need of the patient. Social work, it's typically 1 to 2 times per month, but again, depending on need. And then chaplain visits 1 to 2 times per month, depending on the need. And patient gets to have a say in this. So we have patients who say we don't need a chaplain, we don't need that service, or we don't need the social worker. So it has to be offered, but doesn't mean that patients have to utilize those services. It's important to point out that there are different levels of care for hospice. The most common is routine care, which is just care that's given, as I mentioned before, with those frequencies at home, in a nursing facility, in an assisted living facility. There is an inpatient level of care. So this is often done either at an acute care hospital as a contract with the hospital and the hospice, or it also sometimes done in a hospice house. So some hospices have their own facility while they'll take care of inpatients. That requires that patients have symptoms that are needing very aggressive management, often with intravenous medications or really aggressive nursing interventions. And so patients have to meet a criteria for an inpatient level of care. Continuous care, this is just a little bit below that inpatient level of care, where a patient can still be managed in the environment where they are at home in a nursing facility, but they are needing, at that point, they are needing round-the-clock nursing care. Most of the time this is done at the end of life, but not always. It's just anytime the patient has those symptoms that need to be managed, and then it's just done for that period of time until the symptoms are managed, and then it's moved back down to the routine level of care. And then there's respite care. So hospices must be able to provide respite care for families and caregivers. Most often we see this where a patient is being cared for at home and the family needs respite, and so a contract with a nursing facility, care facility, will be done for a few days, usually around 5 days at a time, to give the family a breather. So with hospice, I mentioned that patients have to meet the criteria of 6 months or less by a physician, has to certify that. So there is a certification process, and then in addition, there's a recertification process. So initially a patient is certified through the first 180 days. So 6 months, as we talked about, they have to meet that prognosis. Now, what does that mean if patient hits 6 months and they have not passed away yet? It doesn't mean that they are automatically kicked off of the hospice, but it does mean that they have to have continued prognosis of 6 months or less. In addition to that, they have to be showing symptoms of decline. So if a patient is completely stable at any point, or if a patient is improving, it does happen where patients do come off a hospice and go back to their regular type of medical care. And typically we'll see that in patients who have a significant decline or hospitalization. And in a lot of cases, hospice comes in and you help the patient to get comfortable, and then they do better, they rebound a little bit, and they may then not need the hospice services any longer. If a patient does, so if it's decided after that first 180 days that patients still meet the criteria to stay on hospice, then they have to be recertified by a face-to-face visit. So an actual in-person evaluation by a nurse practitioner or a physician has to be done every 60 days. That's been a little bit different here with COVID times, because Medicare has allowed those face-to-face visits to be done over video. So we're seeing that, whereas before that was not allowed. So that's hospice in a nutshell, just as far as care delivery services, the team members. And now we'll move on to palliative care, which is newer. So hospice, as I mentioned, still in the grand history of things is relatively new, but palliative care as a specialty is even newer. So the definition of palliative care is a specialty, and this is from CAPC, which is the Center for Advancement of Palliative Care, one of the large national organizations for palliative care. It's a specialized medical care for people with serious illness. This type of care is focused on providing relief from the symptoms and stress of a serious illness. The goal is to improve quality of life for both the patient and the family. So a lot of things I've already touched on so far. Palliative care is provided by a specialty trained team of doctors, nurses, and other folks who work together. And one important thing is that palliative care is designed to work along with other physicians, other healthcare providers that the patient already has in place. Hospice can be done that way too. Hospice really depends on if the patient wants to continue to follow with their primary care physician, or whether the primary care physician is comfortable still following the patient on hospice. In some cases, the medical director for a hospice will take over that care. But in palliative care, it's really designed to work with the patient's care needs that are already in place with their primary care physician, with other specialists. So it's really an extra layer of support. It can be done at any age and at really any stage of serious illness. And it can also be done, as I mentioned, along with other curative or aggressive treatments. So it encompasses a wider swath of patients than hospice does. A little bit about the history. So 1985, there was the first palliative consult service in Detroit at Wayne State Medical School. So they had a team that would do consultations in the hospital for patients who were dealing with these illnesses. And typically those were cancer patients, just because they had so many symptoms. In 1987, the first palliative medicine program with oncology at the Cleveland Clinic developed, again, to primarily deal with the physical symptoms that cancer patients were dealing with. And then over time has evolved to realize that those care principles of hospice that are given can benefit a lot more patients than those who just meet that prognostic criteria for hospice. And palliative care just continues to grow from there. So patient criteria for hospice, again, so CMS does not regulate palliative care in the sense of that they do with hospice. And so patients don't have strict criteria as far as any prognosis. They just have to have a serious illness that we're palliating. The team, so that's different as well. There is no regulation as far as what a palliative care team or program has to have on it. It's really just care that's provided by what the resources are. So if you've seen a palliative care team, and this is one thing that's important, if you've had experience with a type of palliative care or a company that provides palliative care, that doesn't mean that every other palliative care company is going to be handled in the same way. Hospice is predictable. They have to have those core team members at least, and then depending on the size of the hospice, they may have more services or they may have more folks. But with palliative care, it's delivered in a variety of different platforms, and so the team is not always the same between. So it's important to find out what's in your area and how that's provided to be able to inform patients or send referrals for patients. Typically, though, from what I've seen and what's out there, it's a nurse practitioner, so a mid-level provider driven practice. Social workers are typically involved just because of the high needs of those patients, and then some type of coordinator. So this is how our program at Crossroads works. Each team in the community has a nurse practitioner, social worker, and then a palliative coordinator who is in the office and is typically a nurse as well, who is handling phone calls and doing triage and medication refills and just support in the office. And then not listed there, but is typically a medical director. So if you have nurse practitioners, obviously you have to have a collaborating physician, and sometimes physicians are more active and see patients along with their team, like I do. And sometimes they may not, but they have to be able to be available for the nurse practitioners. Palliative care can be performed or delivered in any location, really, which is nice as well. So we have a lot of palliative care patients that we care for that are still at home, also in long-term care facilities, assisted living facilities, or independent living facilities, the hospital, and as well, which is one thing you don't see in hospice, but palliative care can be done in skilled nursing facilities. And so this is a point that I'll stop on for a second because it's important to realize that. So with hospice, you can't typically provide hospice to a patient who is on the skilled benefit through Medicare. So if they're at a facility receiving skilled services, you can't have hospice at the same time, which logically makes sense. If in skilled rehab, you're typically trying to get better, and with hospice, you're not doing those aggressive treatments. And so now it mostly has to do with billing issues, but you can't have hospice at a skilled facility. Now with palliative care, at least in the way that we provide it, and if it's a similar program that provides it, you can do palliative care while a patient is getting skilled services. It falls under the physician services that are carved out of what a skilled facility is responsible for with bundled payments. At least that's where we're at this point in time. It's even more important, I think, with patients who are on skilled services at a skilled facility, because one of the goals of palliative care is to help prevent rehospitalizations, which is a big topic right now among facilities and hospitals, trying to prevent those 30-day readmissions and 30-day mortality rates. So if palliative care gets involved early while a patient is on skilled services, that can be beneficial to the patient, and it can be beneficial to the skilled facility as well as the hospital. So that's an important distinguishment between palliative care and hospice, is that we can do palliative care when a patient is on skilled services. So the team, again, I mentioned that. I think that's might be duplicate there. We also have hospital inpatient palliative care teams. Here in Kansas City at Crossroads, we have a community team where we service about 400 patients, and then we also have inpatient teams in 2 hospitals locally, large trauma centers, and we do consultations with a similar team. So it's just a dedicated team that's there in the hospital to provide care to patients who are dealing with difficult issues and serious illness. And we have a nurse practitioner, a social worker, and then myself, who round on these patients to help provide support and services. And it's similar to what we do in the community. It's just that a lot of those decisions on inpatients are on a more acute basis and happens a lot quicker than it does, because those patients have higher needs more acutely. So the goals of palliative care, we've talked a little bit about this, and I've mentioned a few of these, but when we involve palliative care with a patient in conjunction with a facility or a hospital, our goals are, we're trying to prevent rehospitalizations by managing patients where they are, where they go home to, or where they go to after discharge, to help them from bouncing back to the hospital. That increases patient satisfaction, and that's certainly our goal. Again, the whole title of the talk is to achieve patient-centered care. That really is what we're focused on, is making the patients as satisfied and as comfortable as they can be. And for most, that includes not having to go back to the hospital if it can be avoided. Achieve patient-centered care, which I mentioned. By doing that, we help determine the goals of care for patients. So that's something that really isn't a specialty of itself. Having conversations, and sometimes those are difficult conversations, to really find out what patients' goals and values and level of importance of certain things are to them, so that we can help tailor their care to what those goals are. So again, to reference what I said earlier, if a patient has a goal to die peacefully at home surrounded by family, well, then going to the hospital and dying on a ventilator after 3 rounds of CPR does not achieve that goal. And so we need to put things in place to help patients be able to achieve that goal when it comes time. We want patients to live with fewer symptoms, as I mentioned. We have to be experts in symptom management. We want to reduce the amount of crises. So especially in patients with heart failure, COPD, even liver and kidney disorders, patients with dementia who have frequent infections. Our goal is to prevent or limit the number of flare-ups and exacerbations that those patients have, because that can progress the illness further, and it also increases the likelihood that they're going to need to go to the hospital emergency room. So by doing that, then we lower the utilization of healthcare resources, which benefits most. We help prevent rehospitalization rates and hospitals from being dinged on those readmissions, as well as for nursing facilities being dinged on those readmissions. We're lowering that utilization. It helps insurance companies, and helps patients usually too, especially if they have higher deductibles, copays. Keeping them out of the ER and out of the hospital should be a goal for everybody. And by doing all of that, we should be improving the quality of life. And one aside from that is we're finding out with palliative care, and sometimes hospice too, is by improving patients' quality of life, we often then directly lengthen the quantity of life as well. So just patients, when they have that relief of stress that comes along with comfort, a lot of times they live a little bit longer, and which is good, and it's important if they do have quality of life. And again, it's at the bottom of the list, but it is important, kind of the elephant in the room, that we're reducing costs by doing those things too, which for administrators and insurance companies and other folks involved on the financial end, that's why palliative care can help reduce those costs. There are a few organizations that are large nationally for the advancement of palliative care, CAPC, which I mentioned earlier, and then the NHPCO, which is another large national organization for hospice and palliative care, to help grow palliative care and recognition for palliative care. The care delivery, so I talked about the team a little bit, and then I talked about hospice care delivery. Palliative care, again, is a little bit different in that it's primarily needs driven. The typical care delivery for a palliative care team, at least for ours at Crossroads, is about 1 to 2 times per month by the nurse practitioner and social worker, but it can be more depending on patient need, and it can be more acute or urgent depending on patient need. So if a patient is in a crisis or having an early flare-up or exacerbation, we can see the patient more often. If they do have a hospitalization and they come back home, we typically will see them more often to help prevent that. So it's really all needs-based. One important distinction too is that palliative care can work together with other services that are in the home, things like home health, skilled nursing, physical, occupational, and speech therapy. So again, with hospice, typically you can't provide hospice in conjunction with those types of skilled or aggressive services. Home health is really included with hospice. With palliative care, since the billing is different and it's not bundled, you can provide palliative care in addition to these other things. And so we do that quite frequently. We'll have our palliative care team involved to visit the patient and take care of those specialized needs. And then they may have a home health nurse too to help with whatever their needs are with wound care, or we may have physical therapy in the home to help with strengthening. So those things can be done together. And the care delivery for palliative really provides a full evaluation of medical history, their symptoms, their social needs, their medications, and then we also coordinate that care with their primary care team or specialty care team, and really whoever is involved with those patients. I mentioned this before, so I won't spend a lot of time, but it can be provided really in any location: long-term, skilled, home, assisted living. The way our palliative care is delivered, we don't require that patients are homebound. Now, I won't discuss a lot of this, but there are some palliative programs that call it palliative services, and they bundle it in with home health. So while the patient qualifies for home health and does have to be homebound, they'll provide some type of palliative support for the duration of that home care services. So, but there are others like ourselves that we don't require that patients are homebound. We just come to the patient. So some of the misconceptions with hospice and palliative care both, and things that we're trying to help debunk and provide education for, is that when a patient is receiving palliative care or goes on to hospice, that in some way that's giving up or giving in, or that hospice speeds up the dying process. I hear that quite frequently when we're discussing hospice with patients who might benefit, and they're concerned that all hospice does is just give a bunch of morphine and then you die quicker. And that's certainly far from the truth. There's confusion between the goals of hospice versus palliative care team. I know at the hospital we do consults every day, and it's almost every day that if you go into a room and say you're with the palliative care team, the patient or family member kind of jumps up a little bit because they go, oh, things must be really bad now and we're getting ready to die because they brought palliative care in. So it really takes a careful explanation to the difference between what we do with palliative care at their stage of illness. But those things are barriers, and they're barriers at a lot of different levels, at the physician level, at the nursing facility level, at the patient level, family and caregiver level. We see that a lot. And so fortunately, through avenues like this, we can continue to provide education to that effect. We'll talk a little bit about billing and coding, and won't spend a lot of time on this, but just to give a general overview, because it is important to know the difference. And it is completely different for hospice versus palliative care. So in essence, the take home is that hospice is a full risk model or a capitated model. So when a patient chooses and elects to be on hospice, they switch to the hospice Medicare benefit, or if they have private insurance that does happen to cover hospice too, then they may still be on a private insurance, but for most it switches over to the Medicare hospice benefit. And at that point, then Medicare pays the hospice a per diem rate to take care of all the needs associated with that patient. So the staff, the equipment, the medications, any care that is associated with that patient, the hospice is responsible for paying for. Now, the one caveat of that is the hospice is responsible for paying for everything that is related to the hospice diagnosis or conditions. And so if there is something that falls outside of that, the hospice is not necessarily required to cover that. It would then be covered under their traditional insurance. So for example, if a patient would need hospice because of lung cancer that is metastatic, and they come onto hospice, but then they also have diabetes or high blood pressure, those things are not related to that terminal condition. And so any medications that the patient chooses to continue on that cares for their diabetes or high blood pressure, if they want to continue that, or if it's within their goals of care, then that would be covered by whichever insurance method that was covering that before. But everything else the hospice is responsible for. It's complicated, and so just to kind of briefly go through this. So Medicare beneficiaries who are entitled to Part A and meet that criteria, so the terminal illness, 6 months or less by 2 physicians, they can then elect the hospice benefits. So that's important too. Patient has to choose or elect that. They're certainly not automatically put on hospice if they meet that criteria. In addition, as we see a lot, a power of attorney or a healthcare decision maker can also choose hospice for that patient if they are not able to make decisions for themselves. So then the patient can receive hospice care for 2 90-day periods initially, so that 180 days, 6 months, like we talked about. After that, there's an unlimited number of 60-day periods, but the patient has to still continue to meet that criteria of qualifying for hospice services as far as prognosis and their condition. Of note, those benefits are cumulative. So if a patient comes on to hospice and they stay on for a week and then decide, hey, I don't want this anymore, or I need to go to the hospital, and they choose to come off of hospice, and then next week they decide to come back on, they enter into that next period. So they don't start back over with that initial 180 days. They actually go into the next period. So it is cumulative. Mentioned, hospice providers are paid at a per diem rate to cover all the daily costs associated with it. Of note too, just the per diem rate is higher in that first 0 to 60 days, and then it drops after that a little bit, just with the idea that patients typically need a higher level of care with the first days as you're doing their evaluations and assessments, and then the longer they're on, they may need a little bit less care if it's routine, but then it goes back up again retroactively in the last 7 days of a patient's life, because at that point usually it is taking a lot of aggressive treatment with staff to be with that patient, so that that per diem reimbursement does go up in the last 7 days. As I mentioned a little bit, so when hospice is elected, no other providers can bill except under certain circumstances. So, and those usually have to be approved by the hospice. So if the patient still wants to be able to see their primary care provider, that can be arranged, but usually the hospice is involved, because if it's related to the condition that they're being treated on hospice for, then those services have to be covered by hospice. If it's outside of that, so if a patient is still going to a specialist to treat a condition that's completely unrelated to their hospice diagnosis, there are some modifiers that can be used to help designate that, but it gets a little bit confusing and really outside the scope of this. So, so when a patient does go on hospice through its Medicare A, essentially, that then converts to the hospice benefit, they waive the rights to Medicare Part B payments for service related to the treatment. Medicare Advantage there too. So this slide was put in when Medicare Advantage plans don't have a hospice benefit. So if a patient does have a Medicare Advantage plan, qualifies for hospice, elects hospice, then it would just revert back to plain Medicare. But actually, just as of this year in 2020, Medicare allowed some of the Advantage plans to add a carve-in policy to cover hospice. So, so that is an option for some of the Advantage plans, that they can actually cover the hospice and work on some cost sharing with the hospice in that case. Just a few other tidbits. Hospices must submit quality data, that they can be penalized if they don't meet or they don't submit. I mentioned the face-to-face recertifications that have to be done. Also, when a patient has a Medicare hospice benefit, they don't have a deductible, although they may still have some co-insurance for drugs. And if they have respite care at a facility, they might have some co-insurance for that. And then hospice must bill Medicare in a calendar month. So very differently then is palliative care. Palliative care is still all typically fee for service, meaning palliative care gets paid for whatever individual services they provide. So in a way, it's essentially like these patients are having a doctor visit or a nurse practitioner visit as they would any other provider, except that we go to the patient. They don't come to us. So we bill simply for those visits that we do. And because of that, then palliative care we don't get a per diem or any kind of other reimbursement from Medicare or other insurance. So palliative care, when it's provided, it does not include the costs of equipment or of medications. Those all still go through the patient's primary insurance. Now we can help facilitate those. So if we prescribe medications, or if patient needs some DME in the home, we can certainly write orders for that. Or if they need home health, we can write orders for that and help to facilitate that. But the palliative care does not cover it. The coverage goes through whichever insurance they still have. So palliative care, just to reiterate, it does not change the insurance coverage of that patient, as opposed to hospice, where it completely changes to the hospice Medicare benefit. Palliative, their insurance stays the same, and we just bill their insurance for the visits that we do and the services that we do. So because of that lack of funding is a barrier. When we do home care and we do these long visits that take a lot of TLC for these patients, unfortunately, you don't get paid a lot more for those visits than you would a typical doctor's office visit for something. And so because of that lack of funding or reimbursement is still a barrier for palliative care and being able to provide that to more people. So just to summarize that part, again, of why I think palliative care can be a win-win for everybody involved. Again, as the topic of the whole presentation alluded to, we are here to align patient goals with their treatment. It is meant to be patient-centered care, and they drive the treatment. We help alleviate some of the suffering of life-limiting disease, help with caregiver support, certainly. And by doing that, it's often cost-effective because we are helping to prevent unnecessary or unwanted treatments, hospitalizations, healthcare utilization that doesn't contribute to quality of life if that's what the patient chooses. And that actually there's data that patients can live longer with palliative care, which helps with the misconception that if patients are utilizing palliative care or hospice, that means they're going to die quickly. That is not always the case. In essence, with these services, patients do a lot of times live a little bit longer. So where do we see the future of palliative care? And really, I guess I should say some of this is where I hope to see the future of palliative care, is that it gets away from the fee-for-service payment model and really becomes more of a value-based model, similar to the way hospice is covered. Doing that requires partnering with healthcare organizations like insurance companies, hospitals, and other payer sources for mutual benefit. Again, right now in the state that palliative care is in, palliative care does not make people any money. Nobody's getting rich by giving palliative care, but it's an important service and it's great for patients, and it saves costs for the payers. And so that's a big way that we do promote that, and that I hope as more organizations and payer sources realize that palliative care is cost savings for them and helps achieve patient satisfaction, that it is worthwhile, and that we can move to more of a value-based payment or some type of per diem type payment to be able to cover more services with palliative care. Part of what I hope for palliative care is that we're able to capture patients earlier in their disease process, so that they can have the benefits of palliative care for longer. We still see a lot of patients referred to palliative care later in the disease state than what they could receive help for. And so that's an education point on community partners and hospitals, nursing facilities, physicians, to recognize the benefits of palliative care so that we can get patients on that earlier and help them to be more comfortable. just to talk a little bit about Crossroads and our program here. So we're in Kansas City, Missouri. There's another program in Kansas City, Kansas, and we have 11 sites across the country altogether. It really still is a large family-owned business. It was started in 1995 in Oklahoma by Perry and Clayton Farmer, who still are the owners and still make their way to all the sites and help give support, and great guys. We do some things differently at Crossroads that they've found work over the years, and they it's great for patients because at Crossroads we really do put the patients first. One of those is a gift of a day, which essentially if patients get to design their perfect day, we actually have staff dedicated to designing that perfect day for them, or as close to it as we can get. Some patients' perfect days are a little bit easier to achieve than others, but we certainly do our best to try to give them that wish to have that perfect day. We do Veterans Recognition Program, which is a really outstanding program to recognize our folks on hospice who have served in the armed forces. Just a few tidbits about my duties as a medical director. So right now I oversee the palliative care program, and that means overseeing our nurse practitioners and the caregivers out in the community. And so I do that directly and indirectly. I go see patients with the nurse practitioners and am available for consultation on these patients to help them care for patients and learn about palliative care and become experts themselves. That includes education for our team, but also the community, things such as this to help get the word out about palliative care and hospice both, since we work as a team with our palliative care and hospice organizations. Part of that is to build relationships with healthcare providers in the community, and so that's why we really reach out to hospitals and to long-term care facilities, to skilled nursing facilities, assisted living facilities, just to really show that what we can do to help patients, and it helps those facilities and those practitioners as well. All right, with that, thank everybody for tuning in. And since obviously this is not live, I am available for questions. So if you have questions that have come up at any point in the presentation, you can always feel free to contact me. The easiest way, which I've listed there, is just my email address at brian.hughes@crossroadshospice.com. And again, just feel free to reach out if you have any questions that have come up, or if you have other needs or certain patients that you're wondering if they would qualify or what could be offered, or just challenging cases, you can always feel free to contact me there. So again, thank you everybody for joining, and have a great rest of the day.